Okay, it's 2 o'clock, so let's get started. There may be more people rolling in the next couple of minutes, but we'll start with some logistics and so forth. First of all, thanks so much for joining us today. This webinar is presented by the National Collaborating Center for Healthy Public Policy and the National Collaborating Center for Methods and Tools, also known as NCCHPP and NCCMT. Before we get going, I just want to put in a couple of reminders. First, we will be online for 90 minutes today, so to bear that in mind. We are also recording this webinar, and that will include your comments in the chat. So the chat is visible, and it will also be included on the recording, so we want you to be aware of that when you're typing. We will post both this PowerPoint and the recording online afterwards, and we will send everyone a link by email after we're finished today. So you'll have access to this as well as other resources that are available at the end of this presentation. So not to worry about notes and so forth. Okay, I see I need to speak up a little. Also, our colleague Mylène McGuire is on the line today to help with technical difficulties. Any troubles, please write her a note in the chat and she'll do what she can to help you out. Now we have a lot of people on the line already. We're at 136. And that's terrific, but it does present a bit of a challenge because we want everyone to be an active part of the discussion today. It's tricky and we can't, you know, we'd much rather be talking face-to-face, but obviously we can't do that. At least we're producing a little less greenhouse gas by doing it through a webinar, and the technology's coming along pretty well these days. But to interact, to share your thoughts and so forth, please use the chat box and don't hesitate to use it whenever. We will be scanning it as we go, and if you have questions or comments to make them when they come to mind, and we will do our best to keep up with all of that. And there will be at least one person scanning the chat as we go and then passing the questions along to whoever was speaking at that moment. Also, if it turns out we can't get to all the questions and comments, and there are some that bear more attention, we may come back to them. We're certainly going to read them all afterwards. We may come back to them and then address them more and send responses by email. We'll see about that, though. It depends. But the point for now is please participate, and we really encourage you to use the chat. So we're very pleased to be joined today by Dr. Megan Ward, the Associate Medical Officer of Health at Peel Public Health. My name is Michael Keeling, and I'm here with my colleague Olivier Bellefleur from the NCCHPP. This webinar, as I mentioned, has been jointly organized by NCCHPP and NCCMT. Emily Clark from NCCMT has helped organize today's talk, so we send her our thanks as well. None of us has a conflict of interest to declare. So our national collaborating centers are part of a network of 6 NCCs across Canada, and these are financed by the Public Health Agency of Canada. And while we have the map in front of us, I'd just like to check in with everyone who's on the line and ask you where you are right now. We're about to put up a poll, and that'll give you a chance to click as to which province, territory, or whether you're calling for international. Let's have a look at where everyone is. A lot of folks from Ontario. Okay, so we seem to have most of the provinces and territories represented. Northwest. Hello, folks in Nunavut. That's great. And a good portion of people from Ontario. Okay, great. Thank you. Back when you registered for this webinar, we asked you a couple of questions about your level of knowledge about evidence-informed public health and also about public health ethics. Here's a summary of what you said. We asked you those, and we used your responses in order to help plan this webinar. we thought we'd just share them back with you, the summary form. One thing that we noticed is it seems you're pretty knowledgeable about both of these. Another thing we noticed in looking at your responses was that while you are quite knowledgeable about public health ethics, a lot of people said they were less knowledgeable about ethics frameworks for public health. So I hope that we can address that a little bit today. Anyway, those were interesting responses from you. One other thing we see here is that there's a good deal of expertise and experience on the line, and we hope that you'll be sharing that with the other participants as well as with us. So I'm going to pass the microphone over to Olivier so that he can set up what we'll do for the next hour and a bit. Olivier, take it away.
Okay, thanks, Mike. So given what you've said in the poll, we have 3 goals today. We'll introduce some of the issues that are related to priority setting and decision-making in a public health unit. We'll also use an ethics framework to help us identify the ethical issues that arise in a case study involving priority settings. And we'll provide you with additional resources on evidence-informed decision-making and on public health ethics. So we'll start right away by setting up the discussion with a problem. We all know that tobacco use is a major risk factor for morbidity and premature mortality. And over recent years, thanks at least in part to public health efforts, tobacco use has declined in Canada, but appears to be leveling off. Many Canadians, even those who want to quit, find quitting quite difficult. In addition, there is evidence to suggest that those of lower socioeconomic status are overrepresented among continuing smokers. The chart here represents a difference of about 10% in the smoking rates between Ontario residents with the highest socioeconomic status and those with the lowest. And similar charts exist in other provinces, territories, and countries. So given that we face this public health problem, what should we do? How should we decide? We all know that there are numerous factors that can be involved in framing, motivating, influencing, informing, and eventually justifying our responses to a problem. We have a strong tendency in public health to focus on scientific and other kinds of evidence, but we also know that we can't ignore issues of feasibility, the political context, the legal environment, our value, the mandate of our organization, and its institutional culture, to name but a few. If you can think of other relevant factors that guide or that should guide our decisions, please share your thoughts in the chat box. All of these factors clearly are important. Today we'll focus mainly on 2 of them, scientific evidence and ethical analysis, but we'll touch indirectly many more of them. So given our tobacco problem, imagine that your province's health unit have been asked to support the province-wide Quit and Win contest. This is going to be our case study for the day. The contest, held every year for the past decade, offers prizes to regular smokers who sign up and quit smoking for 3 months. A high-quality systematic review has shown that the program has had limited results in your region. The study revealed that only 1 in about 500 smokers could be expected to quit for 12 months as a result of the contest. The participation rate in the past year was about 0.8%. Most participants are middle-class white females, while the majority of smokers are ethnically diverse and are more likely to be male. Your health unit is expected to contribute $40,000 toward promoting the program, while sponsors offers $40,000 in prizes. Based on the systematic review and the participation rate, your health unit has decided to cease its support for the Quit and Win program and to allocate its funds elsewhere. So the question is, do you think your health unit is doing the right thing? So at first glance, should you support this decision? What do you think? We'll give you another moment to make a vote later on with more information, but it's interesting to see that the majority of people would say yes. We have 40, well, numbers are changing, but 66 people say yes, 39 maybe, and 11 people say no. Okay, that's interesting. We'll come back to that.
Okay, now we're very happy to turn over the microphone to Dr. Megan Ward from Peel Public Health. The case that we're using today is based on a case published in 2013, and Dr. Ward is one of the authors of that, along with Donna Siliska and Sheila Data. But thanks very much for joining us today, Dr. Ward. Over to you. You may have muted your phone, Dr. Ward. Can you do *6?
Can you hear me now?
There it is. Yep. Great.
Okay. Okay. So thank you. So this case study was based on a rapid review on the effectiveness of quit and win contests that was conducted by one of our epidemiologists, Sheila Data. And Sheila and Dr. Donna Siliska were the co-authors with me on the article that appeared in Population and Public Health Ethics, Cases from Research, Policy, and Practice. And so I want to acknowledge the very substantial work done by both Sheila and Donna in developing the case study, and it's really their work that I'm highlighting today. I don't have a conflict of interest to declare. So here was the issue we faced when we started this work in 2010, but I'll preface it with a little anecdote. We were running quit and win contests where people would sign up to win a car if they stopped smoking. And we had signs publishing, promoting this contest all over the region in Peel. And one day our medical officer of health was driving home. His name was David Mowat. And as he tells the story, he screeched to a halt when he saw one of these signs saying, "I did an evidence review in the 1990s and showed these things didn't work. Why are we doing it now?" And so that's why the whole literature review was undertaken. So at that time, we had about 170,000 smokers in our region on a population of 1.3 million people. And we had programming, as was under the mandate from the province in Ontario in tobacco prevention, protection, and cessation. And the Driven to Quit contest was part of the cessation programming. So we were asked by the province to participate in this, and when we had calculated our costs for doing it for advertising and staff time and various other costs, it was about $40,000. And Peel was a very, very high growth area. We were taking in about 30,000 new people a year, and our funding for our health unit really hadn't kept up with that rapid expansion. So we had really limited resources, even though we were a big health department. And so we were looking for the programming that would get us the highest yield in the cessation category. The contest, this Driven to Quit contest, was extremely popular with our staff who worked in tobacco, and in fact, they look forward to it every year. It was quite exciting to see the people signing up, and just the whole sort of vibe in the health unit when it was going on. Was a very exciting time, I guess, for staff. They really enjoyed it. So we did an evidence review at Dr. Mowatt's request. And what the review showed was that there was no evidence of sufficient quality at that time that quit and win contests were effective in producing short or long-term cessation. And we were particularly interested in 12-month, but we're also looking at 6-month cessation mark. And when we took the results of the research that was available and calculated number needed to treat for one person to quit, it was about 500 or so. Further, when you looked into the research, the studies that actually used biochemical markers to confirm that cessation had occurred among contestants showed that self-report estimates were too high, which probably won't surprise you, and that there were other potential study biases in these studies, particularly small sample size, very high attrition rates, and baseline differences between intervention and control groups. Just to give you an example, one of the better studies had an intervention and control group, and the contestants tended to be more likely to be female, younger, and highly educated, and they were more likely to be employed as semi-professional or professional, and they were compared to a control group that was older, had been smoking longer, were male, and were blue-collar workers. So from our perspective, when we then were applying this research, we had 170,000 smokers. We were getting about 1,500 people to sign up for the contest each year. We had a number needed to treat from what we could see from the research evidence of about 500. So as a result of the contest, we would expect 3 people to quit. So when we looked at the numbers then, 3 quitters against the cost of the 40,000 implementation plus the staff time, and actually the car itself that was the prize was in fact donated by a third party. And our question was, should we deliver a program, which we were being asked to deliver, which we believed wouldn't work. And it's not to say, you could get nothing from it. It's just that when we looked at these numbers and the cost, we thought it was too little yield compared with some of the other alternatives. So the decision that we took was to request our funder, who was the Ministry of Health and Long-Term Care. We asked them and said, we would like to not do the Driven to Quit contest, and we would like to redirect those resources to other cessation activities. We would undertake in that case to actually look into the literature for effective cessation strategies that would be appropriate at a population level, and for our population, which is highly ethnically and culturally diverse, and that we would get feedback from all the key stakeholders, because this was a provincial contest and there were a lot of players in Ontario who were very involved and committed to the contest, and we would map out a communication plan for all of this. Well, this actually wasn't that smooth in terms of how that went for us. We were able to redirect the funds, and we did do a lot of internal and external communication. This was actually a very unpopular decision. It was unpopular with our own staff, although they understood it. But of course, they liked the programming, and so And we were going to be asking them to venture into new areas of programming. But among our tobacco regional participants and provincial participants in this contest, we were asked many, many questions about this decision. And I'm not sure that many followed suit, at least initially. Most people, I think, carried on. But we did develop new cessation programming, and ultimately, in terms of our whole tobacco strategy over the years, we have done less and less and less in cessation and more in tobacco policy. That's partly because in Peel region, which is a highly urban region, we have a very strong primary care network. And so there are alternatives for those looking to quit smoking with some support. So that was the decision we took. And I think we could, at this time, open it up for questions or comments.
Thanks very much for that, Dr. Ward. While people are starting to think up questions and type, I'd like to just ask you one. Can you talk a bit more about the alternative programming that you came up with? And
yes.
About the process for arriving at the decisions you did arrive at?
Yeah. So one of the things we wanted to look into was a hospital inpatient cessation model that had a community link to it. So this was an area of programming that had come out of the Ottawa Heart Institute and was being widely promoted, and it had been successful in Ottawa. And this was the idea that, you know, every patient going into hospital would be asked about their smoking status, and then if they were smokers, they would be put through a protocol with the idea that they wouldn't be smoking while they were in hospital, and then there would be support through the telephone and in some in-person support once they left into the community. So the Ottawa population is a little different than ours, but we had a cardiology team at one of our very large hospitals very interested to try this out in Peel. So we signed on to test it out in as our part would be the community portion of that. And we tested that with a whole sort of evaluation protocol, and we evaluated how well that worked in our region. So that was one area. Another area that we explored was to see what might be available through our family health teams, because we do have a strong primary care network in Peel region, and there was some support for NRT coming to family health teams. So we want to see whether we would be able to get support for our smokers in that, and we actually also evaluated that and in fact created a community practice among all of them as part of that work. So that's what we started on initially as the alternative to the Driven to Quit contest. And the second part of your question was? I've forgotten.
Oh no, that was it.
Okay.
We've got a couple been written in from participants. We'll start with Dee. She says, you mentioned there was a shift away from cessation activity and more focus on policy work, and that decision was impacted by the demographic of the population. Could you please explain that a little more, please?
Yeah. So we didn't really think at the end of the day that cessation was our work at a population level, because there were others to do that work. But we thought we would be the leads for tobacco policy. And so we have been building policy year over year in, for example, outdoor spaces, got bylaw there, hookah establishments. We've got it in, we're working in multi-unit housing. So sort of every period of time, we're bringing forward through our Board of Health a new policy initiative. We just brought one in, started in January for smoke-free grounds, starting with the regional grounds, and the hope is to move that out. So that's a workplace policy.
Okay, thanks. So sort of working more at a structural level than at an individual choice level.
Yes.
Another question from Melanie. This is interesting. Is there a way to estimate how much money the healthcare system was saved by getting 3 people to quit each year, and compare this to the cost of running this program? Obviously, that's a lot of directions, but it's presented as such.
So we did a tobacco health status report to look at the cost of tobacco-related disease in Peel Region. It's not that easy to do, but we did use Kai-High data. The reason it's not that easy to do is because it doesn't cover all the tobacco-related illnesses, and we had it for hospitalization costs, but many of the costs are actually on an outpatient basis, and we couldn't include those. But even the very limited sort of data we had, we thought that smoking-related disease in Peel Region was costing, just for those select diseases, about $50 million a year, which is really a big number. So even if, the 3 people, it would depend on, of course, what their sequelae were, what they would individually cost. The cost in this region, just for the very limited data we have, is so large that we thought really we need population-level strategies to make any kind of impact. And then we started to think, well, what can you do with $50 million if you succeed in the cessation prevention quest? And of course, it starts to build communities in lots of positive ways, including health.
Okay, another question here from Lorraine. A question about the appropriateness of having a car as a gift, given that it could pollute and let's see, having a car polluting the environment is not an ethical gift. Did you document other unintended consequences of those doing quit and win contests with cars by public health units?
Well, interestingly enough, we didn't go into that, but the literature does, and they talk about, the importance of the reward being logically tied to the effort. So, smoking cessation and a car aren't particularly well tied together. So we didn't go into that, and it's a great point. But the literature does go into that.
And then a question from Graham. He's interested in this being discussed as an ethical issue when he was expecting some form of economic marginal analysis.
Yes, well, we're a local. I would love to provide that to you. We're a local public health department, and I can tell you I don't think we would have hired anyone capable of doing that as part of our regular staff. But I like your idea very much. Maybe that's an area we can grow into.
Okay, we've got a minute. We can keep going with a couple of questions if you're game to keep going. From Doug, were any harm reduction strategies considered? I'm not sure. Maybe we need to get more specific, Doug, with that one. Debbie, since it takes people an average of 30 quit attempts to be smoke-free, did you measure the impact the program had on encouraging quit attempts?
So we had a lot of conversation with people saying, well, you know, this is really awareness building. And, you know, if people try once and try again and they get encouraged, it all adds up to the number of quit attempts they have to make. I guess my thought about that is that if this is really for that, to stimulate people to try and so on, my question is this the best we can do? Like, what would the literature say are the best approaches to getting people to try multiple times? And there wasn't really anything that we found in that at that time in the literature that suggested that positive effect. So perhaps they would encourage, you know, perhaps these contexts would encourage people, but I think we would actually do a literature review to see specifically what strategies do increase quit attempts.
Okay, and we've got a little more specificity from Doug here. He suggested that what he's getting at is, for example, switching from cigarettes to chewing tobacco. And I guess we could add now that times have changed a little bit since the evidence review and so on, and now we've got e-cigarettes as part of the mix as well. So other options for people to get off cigarettes and taking a harm reduction approach where maybe it's the lesser of two evils, is that something that was considered?
Yeah, so I don't think that I would necessarily consider chewing tobacco harmless enough to switch people there. There's still a lot of oral cancers that arise from that. I think on the broader question, though, when you're a health department that has, you know, I mean, we basically have a handful of people to work in this program area. We're always going to be selecting what we think will have the most impact. And for us, the name of the game, I mean, the endpoints we're driving towards, or the proximal endpoints we're driving towards, are the reduction of smoking prevalence and protection from secondhand smoke to lead to the kind of health outcomes that we want. And there's quite a few choices that could lead you to one of those two sort of proximal outcomes. And for us, we're doing a lot in prevention, and we're doing a lot in protection from secondhand smoke, and that's where a lot of the policy work comes up. So it's not that things individually can't contribute to the mix. It's, you know, who are the staff you have available and the resources you have available, and where do you think you'll go to have the most impact?
Okay, thanks. What I'm going to suggest is that we move on. We've still got questions rolling in. And perhaps, Dr. Ward, you would be interested in having a look at some of the questions that have just arrived, the last 5 or 6 questions in the chat box, and you would have a chance to respond to those as we proceed. Would that be suitable?
Sure. And then just so I know how to get back onto mute, do I do *6 again?
Yeah. And especially when we get going on the discussion about going through the ethical framework and the ethical discussion, we're going to invite you to participate as you wish, okay? So
Thank you.
Either through the chat or using your voice, either way is fine with us.
Okay, thanks.
But thanks very much for that, and we've got some good questions there, some of which are addressed in the review that you used, and some that are maybe not. Okay, so So let's move along. Let's keep this case and Dr. Ward's presentation in mind while we take a more general look at ethics in public health. After that, we'll focus again on the case. But for the moment, I'm going to pass it over to Olivier.
Okay, thanks. And I think we'll come back to some of the issues that have arisen in the chat box during the ethical analysis that we'll do in a few minutes. So why should we take an interest in public health ethics? Well, one way to answer this question is to think about what one has to know to act with professionalism in this situation. It is clear that one needs to know which interventions are effective and cost-effective in order to maximize health with limited resources. And to be in a position to critically evaluate the interventions and adapt them to the local context, it's also necessary to have demographic and other local information. But one also has to pay attention to the direct and indirect effects of our decisions can have on communities, groups, individuals, and even ourselves. It is also important to recognize the values that are being promoted and those that are being diminished. And it is also crucial to be able to deliberate about options, make decisions, and justify them. Ethics can help in these regards, so in a nutshell, that's the reason why we should take an interest in public health ethics. So, what can we use to help us think about ethical issues in public health? Many things can help us. To name but a few, there are values, principles, ethical frameworks, or ethical theories. These can be applied to cases to elicit intuitions, and some professions also have codes of ethics that provide guidance. It is important also to realize that we can often apply these from different perspectives or at different levels to analyze a given situation. At the macro level, or at the level of public policy or population health programs, we can look, for instance, whether the policy is promoting equitable population-wide access to health benefits. At the meso level, or at the level of organizations or groups, we can ask, for example, whether the whole health unit will be on board and support the chosen program or policy. And at the micro level, between one or a few individuals, we can investigate, for instance, the reach and specific effects of interventions because every interaction is different and important. It is very likely that each perspective or level at which we consider a situation will reveal different ethical issues that all have their importance. So when possible, I think it's a good idea to look at all of them, which is something that we already started doing by the questions that arise in the chat box. So today we'll look at those issues with the use of an ethics framework. A framework is a guide that can help to highlight ethical values and issues and serve as an aid to deliberation and decision making. It can help professionals to adopt an ethical perspective, and it is not necessary to be a scholar in ethics to use one. It can provide an entry point and a structure for deliberation, while also providing a common language for addressing issues and values. But even if a framework can be a valuable tool, it will only serve as a guide. It can't replace critical thinking and group deliberation. It is also important to realize that there are many frameworks to choose from. So the one we're about to use is just one among several to choose from, and we don't want to be suggesting that this is the best one for you to use. It's a good one, but we only use it today as an example of what a framework can do. At the end of the webinar, we will share a link to the list of 30 frameworks for public health that you can choose from. Back to you, Mike.
So as Olivier pointed out, frameworks can be useful for helping us to adopt an ethical perspective, and they can be useful guides. He also mentioned that we're going to provide you with access to a great many of these. We've chosen one today as an example. We think it's a relatively good fit for the case upon which we're going to work. But it may have its own flaws, and we would encourage you to have a critical eye towards this as well as we go, and we'd love to hear what your reaction is to this framework, whether it does what we would like it to do. So comments at that level would be most welcome as well. So the one we used today by Schraderbach and all, it was actually, the longer paper is actually written as an outline for an 8-hour module for teaching ethics in public health departments at universities. It's intended to help future practitioners to have some guidance in public health ethics during their training. But it does prove to be adaptable, and we think it's useful still as an ethics framework in 2 parts. The first part is an outline of 7 principles that can be used to help highlight the ethical issues that can arise in a given situation. And the second part is a set of 9 questions that are intended to help guide you as you work through the ethical reasoning involved in decision making. I just want to step back for a moment and attempt to put our case study today and the title of this webinar into a bit of perspective. Okay, we're talking about using a framework, and we're also talking about priority setting. There are many levels in which we can look at these things. And priority setting could mean one thing in one place and one thing in another. It could mean, for example, decision-making about whether to put resources into tobacco prevention or into, for example, improving road safety. Now, we could also look at how priorities are determined within one of those areas, like we're discussing targets and program choices within the area of tobacco cessation. So our focus today, as you can see, is on within a particular target area, but we could also talk about priority setting at that higher level. The reason I bring this up is for a couple of reasons. One, this framework and most of the ones that we see in public health ethics are much better suited to examining a policy or a program choice. Like, what do we do in tobacco cessation? We develop a program and then we analyze it using an ethics framework. That's the standard operating procedure, shall we say. It's much more difficult and complicated to do it at that other level. And while there are some tools out there, there's certainly not as much as there is for operating at the level we're discussing today. So this one is pretty well suited to working at the level we're discussing. All that said, there are very important ethical considerations at whatever level we consider. So doing public health ethics is not unique to this level of priority setting. I wanted to say that. And as a very brief aside, I want to point out that for those of you online who understand French, we're doing another webinar next week. And it'll be similar, but it's going to have a twist. It's at the same time next week on the Thursday. It's also on priority setting. But it's more focused on that higher level of how to figure out which major areas of work to prioritize when you can't do them all. And what are the ethical implications that underlie the choices you make. We'll be doing that with Dr. Richard Lessard, the former medical officer of Health for Montreal. So please get in touch with us after if that's of interest to you. Now let's get on with this framework. Okay, I'm going to propose that we walk through the 7 principles that you see in the left-hand column in order to help us raise ethical issues. I'll briefly describe each one, and then I'll ask you, as we go, to respond in the chat and try to identify issues that might be related to that principle. As we go, we'll try this out. Once we've done that to raise issues, then we'll go to the second part, and we'll spend some time trying to grapple with the conflicts that might arise between competing values or principles. For those of you who took medical or clinical ethics in school, you might have come across some of these principles before. Schraderbach et al. Take up the 4 principles of Beauchamp-Childress from biomedical ethics or medical ethics, and they add 3 more to reflect important considerations for a public health perspective. So, without further ado, let's step right into it, and we'll talk about the first principle, non-maleficence. This principle, according to the authors, is about ensuring that a health professional does no harm, or at least does a minimum of harm, given that sometimes you have to do a little bit of harm to avoid greater ones. But let's just simply start with this. Will the proposed intervention harm anyone? Now I invite people to give that a moment's thought and start typing in. Can you think of any ways in which this program could do any harm? We've got people typing, that's good. Opportunity cost. So one way of framing that, you could ask, is someone being harmed by the fact that they're not being helped by something that is differently or more effective? So yeah, there's one. It could get some people to start smoking to win the prize. There's a thought. That would be a real backfire on the program. Anxiety over failure to quit. That's an interesting point because that will, perhaps the program will inspire people to make an attempt and, yeah. And then failure would perhaps have repercussions, especially in a context of, if I can't do it with a chance to win a car, when can I do it? Not addressing other health issues, that's kind of like opportunity cost. Oh, that would benefit a larger number of people, okay. More effective for a population that is not the target population. That's something we'll get to later as well. That's a good point. Winner could die in a motor vehicle accident, or motor vehicle crash, excuse me. Resources could be used more effectively. Yeah, that's the idea. There are some potential harms in there, and that's getting us going. Keep adding them in. Just identify if you're typing in a harm. Just make sure you put in the word harm as a keyword as you type, and I'll move on to the next one. Pretty well known, beneficence. Now, as a complement to avoiding harm, we have beneficence, which is, simply put, doing good. It seems like it's a mirror of non-maleficence, but there's another dimension to it because it also implies a positive duty to do good and not just to avoid doing harm. So there's a positive active part to beneficence, as in there's a duty to do something. So let's identify, in the same way we did with harm, let's identify some good and to whom good is being done by such a program. So we'll go ahead. Let's think of who could benefit from this. And one thing in the way this is asked, it says, will it benefit every involved or affected individual? I take every in that sense to mean smokers. But there are other ways in which people could be involved as well. So what have we got? The 3 quitters each year, for sure. Advertising for the automaker. Someone's benefited by having a car. Community partnerships, increased awareness of smoking effects, and the awareness part is one that's clearly part of the program. There's an information campaign involved as well. Persons ready to quit that need an incentive, very good. Boosts health staff morale. Olivier?
It's interesting to see that some people attach benefits to having a car and others see a harm. Mm-hmm. You see that person may stop going to work by walking or may even get hurt in a car accident.
It's interesting because a big regional public health unit will probably have a team working on reducing injuries and increasing active transport and increasing the use of transit rather than cars. So you've got, on the one hand, part of the health unit working with a program that gives someone a car, another part of the health unit acting to reduce the use of cars.
And another good point related to the idea of having a gift, a car as a gift, is the idea that it only reaches people who drive or who want to drive. So it doesn't address for the teens or the people who don't drive. Good point.
These are really good points that we're seeing in here, and I hope that everybody's keeping an eye on the chat. Let's move on to the third principle. Let's keep in mind these as we go along. The third one is a big one. It's, well, the authors identify health maximization as being a value that goes right to the core of public health. And unlike non-maleficence and beneficence, which are focused on each individual, this one takes more of a population-wide perspective. Now, as we know, public health interventions, they tend to set health maximization as a sort of a goal, and it's often the standard by which interventions are evaluated. After an intervention, people ask, did you improve the population's health, and by how much? And of course, there's a very important dimension in there, which is treated in other ways about which parts of the population and which individuals. That's obviously really important, but in general, health maximization is certainly a big standard and also an evaluative, it's a cornerstone. So one thing to note here is that there's a big difference between focusing on the aggregate of each individual versus focusing on the whole population. Because not every individual will consider him or herself to be benefited by vaccination, for example. But at a population level, if we don't have a big enough percentage of the population immunized, we won't get the protection that comes with herd immunity. So that kind of example is one that shows the tension that can arise between beneficence or non-maleficence, a tension between those and health maximization, or between individual and group benefits. So while we've got health maximization up, let's quickly ask, and we've touched on some of these already based on what Dr. Ward had to say, but is the intervention effective? Is it evidence-based? And does it improve the health of the population? Let's quickly have a couple of responses here. So while you are typing, or while a few of you are typing, I'm going to just continue with another thought. One way that we've found to be very helpful for us when we're working through a framework, really helpful for us to understand what an intervention is supposed to be doing, is to produce a simple logic model, like the one you see on the screen now. And its function is simply to show the main steps between the actions that the program tries to inspire and the health outcome that we want. So the health unit supports the program. We get public participation, i.e. smokers participating in the contest. We get smokers quitting for 3 months. We get many continuing to live smoke-free. We reduce morbidity and mortality. That's the basic outline of what is supposed to happen. One thing we like about logic models is that they stretch it out a bit over time, because at different points in the process, they give us a different notion of, well, what matters here? And what kind of evidence would we need to find out if this thing is going to work? Because every link in the chain has to work for the program to achieve its intended outcome. Also, each link in the chain can show us places where there are different implications or different weak spots from an ethical perspective. So we got people writing in about health maximization. Okay, not too much. As we saw, though, there is an issue of effectiveness with this, and a couple of the points. One is the effectiveness data from the systematic review. Also, the issue of the program reach being out of sync with the demographics of smokers in the health region. Would you like to speak any more to that one, Dr. Ward, or shall we move on? I think what you said already was pretty clear in speaking. Yeah.
Again, I was just going to say that our smokers in this region are men from 20 to 50 years old. And so even within the studies where there was some effectiveness, you got most effectiveness not with that population demographic. Also, we have very, very low smoking prevalence among people with higher education and in professional groups. And so, again, the studies didn't really match very well our demographic of smoker. And we know a lot about our smokers because we did that health status report specifically. So we were actually working with more data in that case than just the research data.
Right. We also have a couple of comments or questions here about related issues. One is from Barbara. It will be difficult to quantify its effect as this program will start conversations about quitting that are not interested in the car but interested in stopping smoking through other interventions. And that goes back to the kind of awareness issue. So certainly that could be an other benefit or an other effect of this program. So separate study would be needed to really clarify what was going on with that. And then Louise says a longitudinal study with winner of the contest might be needed to verify if it's a long-term success. And I think, quitting for a year and quitting for an even longer term, that would be definitely something to find out about. Okay, let's move on to efficiency. Now, it's a little tricky to separate efficiency and health effectiveness. They're close related, or to health maximization, I mean. They're very closely related, but they are different because health maximization is more concerned with effectiveness or having the biggest health impact, whereas efficiency is more about having that impact realized in the most cost-effective way. So this is an ethical issue because we don't normally have enough resources to do everything we need to do or want to do. So arguably we have a duty to do the most we can with the resources we do have in order to fulfill our mission. So efficiency, we would certainly argue, it has a strong ethical dimension. It's not just numbers. So we will simply ask, and this is a question that has already been addressed in certain ways, but any further thoughts? Is the intervention cost effective? And would the resources be better directed to another option? So any additional thoughts? Now is the time.
I would be interested if Dr. Ward wanted to comment on this issue, but I would be interested to know if there was any discussion at the time of whether this money should stay within smoking cessation or go to another public health problem.
Yes, it's Megan. So we had done a comprehensive health status report just before this, and we had identified tobacco as one of 4 key areas that we wanted to work on, and that was because of the cost in terms of morbidity and mortality, just the plain suffering of people in Peel region that we were seeing in our morbidity and mortality data. So we did want to focus what resources we had in tobacco. It was a strategic direction for us. And we were trying to sort through, with the handful of people we had, where to kind of fully maximize them to reach as many people as possible. So we didn't think about moving them elsewhere because it was a strategic priority just because of the burden of illness that we were having in this region.
Okay, thanks. I thought it might be something like that, but I wanted to hear it. Sophie Bart asks an interesting question, but I'm not sure I have enough elements to answer it. She says, efficiency is not only about cost effectiveness. Is this relationship built into the framework, or is the presenter's interpretation? The way it is presented in the framework, if I'm not mistaken, is really in terms of cost effectiveness. It's not, efficiency can have many meanings. It's not the idea of responding to the most preference of people, as economists sometimes use the term. It's really in the sense of, is it the most cost-effective way to improve health?
Okay, thanks for those responses. Let's move on. We're at 3 o'clock, so we've got about half an hour to go on our schedule here. So respect for autonomy. This is one with which many are familiar. According to the authors, it's about ensuring that individuals' choices and preferences are taken into account. In public health, when we operate at a population, policy, and program level, it's easy to overlook certain individuals and groups. So what that means is that there's almost by definition a built-in tension for public health, because interventions built to advance the common good can go against the good as identified by some individuals. So in order to bring those considerations into play and to make sure that the will of individuals and their own interpretation of their good is respected, we ask these questions. Does the intervention involve coercion? Is it paternalistic? And paternalism, in a very simple definition, is roughly doing good for someone against his or her own autonomous wishes. Does it promote autonomy? And are personal data and privacy handled appropriately? So tell us what you think. Are individuals being respected here? Certainly the program design would have to take into account things like how to appropriately use what data people are, the data that people give in, what is an appropriate use of that data. And typically with contests, winners are made, their names and faces are made public and so forth. So clearly that stuff is part of an informed consent process and making sure that people are clear what they're getting into and how their data will be used. But also the handling of lists, consent, etc. The choice to participate, certainly, and that has to be an informed choice.
There's an interesting comment by Lauren Tilford from a critical perspective on the framework itself, saying that there are numerous other dimensions that we should look at. And this is very important to think critically about the framework that we're using today, but any other framework, because a framework is never going to be complete. So it's a very good idea to raise those kinds of issues.
Yes, that's a really good point. And public participation in the design process, particularly from groups that are marginalized, if that's something that ought to be brought to the foreground. Probably the best shot we have at touching upon those things is found under considerations with respect to the principle of justice. The concept of justice underlies our thinking about equitable treatment, equal opportunities, and fair distribution of the physical, social, and economic goods and opportunities that lead to health. So this is probably the best place to consider the expressions health equity, health inequalities, and social justice right here when we're considering justice. So it's a big one. Along with health maximization, social justice is arguably one of the pillars of what public health is all about. So let's take a moment and think about this one by considering the questions that the framework suggests. Does the intervention involve or provoke any stigmatization, discrimination, or exclusion? And that, was it Lorraine who asked made the earlier comment about consulting? That might be a place where that could be highlighted. Perhaps it could be better highlighted by this framework, but discrimination or exclusion, both in the process and in the way in which the program is run. Will it reduce or increase social and health inequalities or inequities? Will vulnerable subpopulations be considered and supported? And there it is. Will it enhance or corrode social cohesion and solidarity? So take a minute and let us know what issues arise based on these questions. Take a minute.
There was an interesting discussion in the chat box that led from autonomy through justice by saying that if the gift is big enough, it might coerce some people who don't have the means otherwise to have access to such a good. So it's interesting how justice and autonomy can be linked when we think about what is going to be coercive or not. Good point.
There's one consideration here, and I think it goes to what Dr. Ward mentioned earlier. With respect to the groups that tended to use the program versus those who tended to be the smokers, what we see over time as non-normalization of tobacco use continues, and well, we refer to a paper from 2004, a European paper by Kunsteal. They talk about smoking cessation. In Europe, they say, smoking followed the tobacco epidemic model, according to which large inequalities appear in the latest stages of the epidemic. And what that means is that smoking is harder to tackle amongst the least well-off, and the efforts to cessation efforts, shall we say, would tend to help the better off more than the least well-off, so that successes in cessation will tend to benefit the more advantaged, thereby increasing the gap. So when we're designing tobacco control measures of any kind, that's something to keep in mind. And the authors of that paper, they proposed something called equity-oriented tobacco control, a way of building equity thinking into programming so that at the very least they wouldn't increase gaps, or they'd increase them the least possible as smoking becomes more and more denormalized. So what do we got? The gap in smoking rates will continue to widen between the population most likely to smoke and the rest of the population, yes. And not in a linear fashion, but there will also be a tendency for less well-off socioeconomically people to still be smoking. There'll be more of a gap there. Smokers are being rewarded for stopping doing something they shouldn't be doing in the first place. Okay. So in a way, that's a reverse look at the justice issue. So that smokers are doing the wrong thing, they're getting a reward for stopping doing the wrong thing. Perhaps those resources ought to go. Perhaps it's implicit in this that resources may be used better elsewhere. I don't know. Okay, something about peel demographics. And yeah, I think that's a really important thing to identify that the study was considering peel, and other health regions might have completely different demographics, and different considerations would then apply. So you don't want to apply too broad of a blanket upon a program that was run across the province. It's very location specific, and the demographics and the data are also location specific.
Can I just add something in there? We did a literature review, and there were studies from all over. What we did then was apply it to our demographics and our context. And it is true, you know, we have a big primary care network in Peel. I think, and so we don't actually focus much on cessation at all. But I think in areas where there is less support for smoking cessation, then you have to think more deeply about what you're going to do to get the kind of reach you need. It's not clear to me that a contest is where you would go if you were in that situation. But it is, our analysis was based on both our tobacco health status report and our comprehensive health status report and the review of the literature.
Okay, thanks. Just quickly move along. And the last principle that Schrader-Bacchiol presents is that of proportionality. Basically, this one is about balancing benefits and harms, but it's also about keeping infringements to autonomy, for example, in proportion with the goods that can come from that. That's just one example of balancing benefits and harms. But if you're going to press on one value, then the gains that you can realize by doing that should be sufficient or in proportion to that harm. So, as Olivier just mentioned in the chat, he was talking about paternalism. Perhaps we could say a little paternalism is considered by some to be worth it if big benefits can be realized. But that's what the analysis of paternalism is intended to show, or at least that's what proportionality asks us to take into account. So I'm going to continue on in the name of time, and we will take a little pass through the second part. Oftentimes we spend too long on the first part, just raising the issue, because that is a good place to start, at least, in terms of being able to see and identify issues as you go along. It's much harder to grapple with them and to make decisions. But so the second part, generally, is about dealing with the tensions that arise and trying to balance them out and trying to arrive at a decision. There are a number of steps that we will simply pass by, but we want to touch in on a few of these and have a little go and see what comes up. So let's start with this. Very, very simple term. Identify the issue in your own words. What is the underlying moral conflict? That asks us to step back a little and just say, okay, what is the issue here? What's the problem? So, would anyone like to take that on?
I will take the time to answer very briefly a question about proportionality that has arisen. The question is, what should be included in this analysis? And the way it is used in the framework by Schroeder-Back et al. Is really about balancing the burdens versus the various benefits. So it is meant to be far-reaching in terms of what it includes.
So one person identifies the problem as being that valuable resources could be redirected to support the greater good. Okay. Another way of identifying the conflict here is there's a measure of momentum for the program, and a lot of people want the program to happen, and that is in conflict with, in a particular region, what the evidence says isn't working. So another issue is that of the problem of potentially increasing health inequality by putting resources towards this in order to reduce smoking when it could go elsewhere, or be a differently targeted program to try to identify the lower socioeconomic status smokers in the region. So what they want here is to just get in plain language, what is the underlying moral conflict? And what they ask us to do after that is to translate that into the language of the principles that we've started by talking about. And this is a bit tricky with this case. In other cases, it might be more easy to work through. But one way of looking at it is, let's remember what we said were the benefits, or what came through beneficence. Some people were helped. Some people liked it. And there's perhaps a little bit unknown amount of good being done through the information campaign, or perhaps an intention that may flourish down the road, but there are goods there. Those stand on one side of the issue, and you might say that they stand in opposition to 1, health maximization, 2, perhaps efficiency, and 3, certainly justice when we think in terms of inequalities. There are various ways of interpreting the issues with respect to justice, but is it a good use of dollars? It's doing good in some places. Is that where we want the good to be done? Now, questions number 3 and number 5, both of these are, I think, really good questions because what they call upon us to do, they call upon us to take a second look. And I view these kind of as signals to apply our critical thinking and to not go into sleepwalking mode and simply go through things by rote. So, do we have all the information we need? What do we need to learn more about? We can't deal with that today, but I just do want to highlight that one as well as further interpretation of principles in particular. With more information, does your interpretation change? They ask you to revisit your thinking about how you read and thought about the principles. So just to say, very important to keep a critical lens upon the work that's going on. Now, what alternatives are there? Are they feasible? Do they reduce moral issues or tensions? Does anyone have anything to add into that? Keeping in mind what Dr. Ward already said about the alternative that the health unit came up with, that was based on further research, and they looked for a way of redirecting those funds. So I think we can continue on, but just to say that this framework has you do that work. So I think this is a very good question because we talk about the principles that are in conflict, and then it asks you, is one of them being pushed more into the foreground? I want to ask if among the 7 principles that we briefly talked about, does one of them jump out? Do 1 or 2 jump out? Let's hear what people think. Okay, proportionality and beneficence, all right. Non-maleficence, not doing harm, okay. Going to move forward here, and beneficence, efficiency, they jump out, okay. And what we talk about when we talk about one being pushed forward, we're talking about how and why we will end up making the choice that we do. We say, well, in this case, for example, if beneficence and efficiency are jumping out, these are the reasons why we're going to favor doing things this way. It's not an exact science, but it's a reasoning about what pushed you that way. You say, in this case, okay, beneficence and efficiency. And that will inform what is judged to be the solution to the problem. Okay, and whatever we conclude, and whatever the solution to the problem is, the 2 steps that follow, taking a look at the integrity of it, and finally number 9, these reflect the importance of recognizing that the choice that is made in terms of what is the solution, it's going to become a public choice. And the decision you make can be done more transparently by using an ethics framework and by documenting the process as you go. Because that documentation can, one, you can say, well, here's why we did what we did, and here was the thinking that went into it, and at least you've got a process laid out. So in terms of transparency, that's helpful. It also helps you to improve upon the process that you've developed over time. You get better at it. You document it. You say, well, okay, here's what we did last time, and look what happened, for example. One last thing I want to mention is just to highlight that this framework, it puts evidence right into the ethics framework. It's integrated, and the importance of the evidence is integrated into the ethical analysis. And I think it's important to reflect on the way in which those things are operating together in harmony, and rather than just considered to be completely distinct. Okay, we're at 3:20. I think we have time for questions and discussion. I haven't had a chance during this moment to look at the chat, but if there are any questions or comments to make.
There's a question in the chat that I think is quite interesting about the framework itself.
Okay.
It asks, this framework seems to be, well, I'm interpreting the question, but it seems to be good to analyze one option. Are there frameworks to compare between options? And I would say that this framework could be used to compare between options, but as Sophie said, you'll need to run this framework on the different options in order to compare them. Most of the frameworks are like this. Those that we know of that ask you more directly to compare between options actually just provide you with some sort of grid in order to do the same exercise several times, and then by having an overlook of several options, try to help you to decide what to do. But it's not, no framework that we're aware of are meant to be used as pure algorithm that will lead you to a decision between options. So yes, the idea most of the time is to run the framework on different options and look at alternatives.
Those are really good questions. Thanks. While we're here, and maybe people are going to pose a few questions along the way, but let's ask you one more time. If you're of the same opinion, or would you support the decision to not run the Quit and Win program in that region? Let's see if people are of the same opinion or if it's changed at all. Oh, looks like a few more people support the decision than before. I think before we were at around 56% yes, 35% maybe. Now we're at 89. Interesting. Now, for those of you who changed your opinion, maybe you could write a quick note to say what it is that changed your opinion. Just more time to think about it, or was there some specific thing that you saw along the way that helped to convince you? Support the decision that was made by the health unit. Support the decision to not run the program, yes, and to reallocate the funds. That's what the question is about. Good point, Lorraine. So, 91 to 8. Let us know if your opinion changed during that. Why? Now we have maybe 5 minutes or so for a couple of questions or comments if anybody else has some thoughts.
I would be interested to know, Dr. Ward, a lot of this case rests on the idea of efficiency and health maximization. And you mentioned that the decision to stop allocating the funds to the Quit and Win program was contentious, both politically and for the staff itself. So I was wondering if we take a long look at the effect of this decision, would you say it is still, does it have a lot of backslash that would maybe not change the decision, but that would need to be taken into consideration when we think about the effects on health maximization and other variables?
A couple of things. I don't think we've ever looked back, to be honest. on this one. It was some years ago that we took it. We moved on. But I noticed that David Mowat was actually on the line. And one of the things that I would say was extremely helpful was he was our medical officer of health, and he said to everyone, Sheila who wrote the paper and staff involved, that he absolutely stood behind them on what they had found and what they wanted to decide to do, and he was prepared to be a public face and voice to that. And when you're first starting out in this business of trying to put evidence to these kinds of decisions, having the CEO say, I'm 100% behind you, is a really good and positive message. So even though we had to have a lot of conversation with colleagues, other health units, and the ministry and so on, just that support at that level as we were having those early conversations very helpful. And I mean, we've put this way of looking at evidence into decisions into our practice now, so it seems a bit like a long time ago. But in the early days, that was really important.
That is a good point, thanks. And it really also sent the message out that evidence-informed decision-making is really important in public health also.
Yeah, thanks very much for that. I want to turn over the microphone for a moment. Are you on the line, Emily?
I'm here, thank you. Great.
Emily Clark from NCCMT just wants to help point us towards some resources that are available from NCCMT. And,
Great. So
go ahead. I'll move the slide for you when you're ready if you want.
Thank you. Thanks first of all for a great webinar. I just wanted to point out a couple of resources that NCCMT has to help you with the evidence-informed decision-making part of using evidence in your ethical decisions. For example, we have the Understanding Research Evidence videos. These are hosted on our site. These are 5 to 10-minute videos that explain basic research concepts, things that you are going to come across when you're looking at the evidence. For example, we have about a 6-minute video that explains how to understand the number needed to treat, which is something that Megan Ward went over a little bit, and this is a very nice summary of how to understand that. There are a number, there are about 10 other videos in there as well, how to understand a p-value, how to calculate an odds ratio, all things that will help you in understanding the evidence in order to make these decisions. We also host the Registry of Methods and Tools. I'm going to highlight one tool in here, the Priority Setting Process Checklist. This is developed by Public Health Ontario. It's a 6-step framework that guides health promotion planning. It's organized in a checklist format that you can print out and use. There's a ton of resources in there as well for other activities like critical appraisal of evidence, adapting programs, and how to plan and conduct organizational change. And then finally, as a bit of a more general resource on the next slide, I just wanted to direct your attention to the online learning modules. These are free modules you can complete at any time online. You have to create an account, but you can complete them individually or as a group with your colleagues. They take a couple hours to complete, but they're very interactive. They cover a range of topics like critical appraisal, different kinds of evidence, assessing whether or not evidence is applicable or transferable to your context, assessing stakeholder involvement, and implementing and evaluating knowledge translation strategies in public health. And yes, I just see in the chat box, all NCCMT resources are available in French. The research evidence videos, we have a different speaker doing them. We have a francophone who has done those videos, but they are all available in French as well. Thank you so much, everybody.
Thank you, Emily. Here are a few resources from NCCHPP on public health ethics. We have many more on our site, so we invite you to come and have a look. As I said, we will be sending an email to everyone afterwards with links to this PowerPoint and to the recording, as well as, and within the PowerPoint you'll find those resources. We really want to thank Dr. Megan Ward for joining us today. It was great to have you on the line sharing your expertise and your experience. So thanks so much. It's very much appreciated. And for those of you who wish to obtain continuing education credits, in that email that we send out later, there will be a link to an evaluation form, and through that you can get to the form for continuing education credits. So that'll be available to you either later today or tomorrow.
Megan, I'd just like to say thank you to the NCCHPP and NCCMT. I've actually learned a lot from those centers in preparing this, and also for the really interesting comments on the chat box. I've learned a lot.
Thank you so much, Michael and Olivier, for putting this together. You guys did a great job.
Well, thank you. We strongly encourage anyone to who wants more information or who has comments, etc., to please contact us. We would welcome emails, and we'd be happy to start a conversation. So many thanks to all. Sorry we had to rush things a little at the end, but I hope it proved interesting. Thanks again for joining us.